Good morning, PT on Ice Daily Show. How is everyone doing today on this fine Tuesday? I hope everyone is awesome. The PT on Ice Daily Show is brought to you by the Institute of Clinical Excellence, and I will be your host today, Dr. Lindsay Huey, lead faculty of extremity management, along with Dr. Eric Chaconis and Dr. Mark Gallant. So happy to be with you all on a Tuesday. Good morning, everyone that's waving. I always love that. Today, I am going to talk to you. Today's title is Not All Patellofemoral Pain Syndrome is Created Equal. Should we subgroup? So, I'm going to talk briefly about patellofemoral pain syndrome and then discuss what potential subgrouping would look like, list a few benefits of subgrouping, and then end with a 5-step fitness forward approach to helping humans with patellofemoral pain syndrome. Before I dive into that, though, I'd love to share with you upcoming courses. So I was with you last Tuesday and shared what's coming up in extremity management world. It is a busy year for us. We've really doubled, almost tripled our offerings from years past. And Mark Gallant and I are really excited to be on the road. We will both have courses at the end of March, March 26th and 27th. I'll be in Nebraska. Mark will be in New York. And both of those courses still have availability. So we'd really love to see you there. And then as we get into spring, a little further, I will be in California April 9th and 10th in Santa Rosa. That course is shaping up to have lots of folks. So sign up if you're thinking about getting out to wine country. In addition, I will be in Florida. And can you all still hear me on Instagram, by the way? Give me a thumbs up if you can, because I just got a notification. And even though I thought I turned those all off, one still came through. Okay, cool. You can hear me all right. Thank you for whoever sent that through. And so, Florida, be there. We haven't we have limited number of signups, but no one signed up quite yet. But if you're thinking about it, it is beautiful. I got an Airbnb right on the beach. It's gorgeous. I highly recommend making it a little getaway plus some learning. Again, thanks for the thumbs up, everyone. And then as we move down deeper into spring, we have courses in May and July. Mark will be in Wisconsin. In Onward Milwaukee, which is so beautiful, just seeing the pictures with Kelly Benfee. So please look at all of our course offerings, through the fall. Again, I could keep going, but I want to chat about patellofemoral pain syndrome. So let's get to the topic at hand and chat about subgrouping. Before I do dive into what subgrouping might look like for this population, let's just orient ourselves to that population, right? And its kind of prevalence and incidence. So it's one of the most common knee pain disorders. You heard me talk about knee OA last Tuesday. If you join me, if not, take a listen. But this is one of those next up. It's very prevalent in military populations, in our runners and adolescents, especially those playing some kind of sport. When you look at some of the facts, and there are lots about the incidence and prevalence, about 90% of patients with patellofemoral pain syndrome, they go on to have chronic symptoms. So up to 4 years of symptoms after diagnosis. And there's a decent percent, about 6%, that are still not symptom free. 10 plus years down the road. So our patients, our humans are living with this knee pain and just kind of pushing through. And so I think we can do better. And I think subgroups offer an opportunity to really place patients in buckets, which further dials in our treatment. And then in theory helps improve outcomes, helps us improve our outcomes more readily. This human, when we think about clinical exam, what does the human with patellofemoral pain syndrome look like? It's that person with reproduction of retropatellar pain or peripatellar pain during squatting, during stair climbing, sometimes associated with prolonged sitting and then getting up. But it's really that squat that is that go-to diagnostic, and then tenderness palpation along that peripatellar area. when you look at the literature and evidence about, what is going on in patellofemoral pain syndrome, when you look at the expert consensus statements from the International Patellofemoral Pain Research Retreats, that is a mouthful, and it is a real thing. They propose a lot of biomechanical risk factors being on board for patellofemoral pain. And those three are some proximal issues, such as hip and trunk weakness, specifically in the hip extensors and abductors. And then locally in and around the patella. So, secondly, we'll see local deficits in and around the patella, including quadriceps and hamstrings weakness. And then patellofemoral joint, often some hypermobility, but there's also hypomobility present as well. And then distally, we see some lower leg and foot issues, such as excessive pronation, um, around the ankle. So if you've seen these patients, you kind of know all that, right? That's just to orient our population, and what I'll be discussing today. So for subgrouping, Selfie et al. In 2016, out of the British Journal of Sports Medicine, he undertook trying to subgroup and looked at 127 patients, and he performed a detailed characterization study where he really looked at not just those biomechanical factors that I spoke to, but it also looked at patient demographics such as age, sex, time onset and duration of pain, visual analog scale. And he also, the team looked at the following clinical tests to try to subgroup patients. And those were looking at rectus femoris length, so flexibility there through the passive prone knee flexion, looking at passive knee extension and supine to look at hamstring length, calf flexibility and standing. They used an inclinometer for that. They also looked at hip abductor strength, quadriceps strength, as measured by a handheld dynamometer, and then just total patellar mobility, medial plus lateral glide. And then finally looked at the foot posture index to look at overall foot position, foot pronation. And so all of these factors were put in, and then out of the 127 patients, so a pretty decent group of individuals that actually completed the study when they looked at all these factors, here's what Selfie et al. Found. So the three groups that were common were named weak and pronated foot, weak and tighter, and then strong. So these were those three categories of humans that were found. So three main buckets. Now here's a brief summary of what those buckets look like. And I hope you'll all pause and kind of reflect. Oh, I've actually seen these buckets in the clinic, but maybe weren't distinguishing them. And so when we think about the weak and pronated foot, this is a subgroup of individuals that exhibited really high functional disability. And they also had the greatest patellar mobility when they looked at the medial to lateral. And then when we looked at patient factors, this was usually a younger subset of humans, and they had the shortest duration of onset of patellofemoral pain. The next group, weak and tighter subgroup, they had weakness in their quadriceps and hip abductors. So they had the highest mean here. And they were overall less flexible in one of the length assessments, whether it was gastroc, hamstring, or quad. This weak and tighter subgroup had significantly higher BMI, worse functional outcomes when classified in this profile analysis that they did. And then they trended towards overall lower physical activity and longer duration of patellofemoral pain. And then finally, that third group, the strong subgroup, is composed more of males with lower body mass index, higher levels of function. Um, their pain scores were lower, significantly lower, and they tended to have higher function. They also had the highest mean quadriceps and hip abductor strength, with the most flexible rectus femoris of all the groups, which I thought was interesting. You don't typically think of the male human as being flexible here, but um, so when we think about all these three subgroups and kind of the findings, I think it can be really helpful because patellofemoral pain is pretty heterogeneous, right? Even the subgroups I just listed, some of you are probably thinking, I see a lot of overlap there. And, in the study, they saw that too. There is overlaps amongst the groups. And we really have to acknowledge that, no two humans are alike and have the same exact impairments. And we know that not everyone's going to respond to the same interventions the same way. And even this Selfie et al. Study was not validated. So I have to let you know that this is something that still needs to be looked at and studied. But I really think, despite not having validation, this is a step in the right direction. If we can start thinking about these three buckets, it'll really allow us to have a more dialed and focused treatment base based on common impairments to that subgroup. In addition, it serves as the standard recipe base for them that takes into consideration the whole human, right? Some patient profile factors plus some impairments. And then I really think subgrouping allows this opportunity. And in my clinical experience, like managing low back pain, we see subgrouping being really helpful in helping with efficient outcomes. So, no matter what subgroup, the patient you're seeing that has patellofemoral pain syndrome falls into of the three that I listed, I want to tell you ICE's five-step fitness forward approach to the human with patellofemoral pain syndrome, regardless of what bucket they fit in, and how we approach patellofemoral pain syndrome at ICE. So, number one of the five, we're going to modulate symptoms to maximize fitness. Dr. Jeff Moore said that. And if you've been to one of our courses, you've heard that quote because it's really a pivotal one for us and one that's at our core, and that we really feel like you can't facilitate fitness in the human if you don't take the time to modulate those symptoms and modulate irritability and dampen that before you load them up. And so this may be through taping, myofascial decompression like cupping, and or manual therapy directly to the patellofemoral joint, and or even um, treating the lumbopelvic unit. So maybe a lumbopelvic manipulation to dampen pain and irritability. Number two, we're going to be doing quadriceps, hamstring, and glute max strengthening. Number three, it's these humans need reactive neuromuscular control exercises to control that whole chain. Think back to those biomechanical factors I listed in the beginning. And then they're going to have some kind of lateral hip progression as number four, where we're really loading up those hip abductors and then those external rotators as well. And then finally, step five is there's going to be multi-segmental functional retraining on board, specifically that squat, because that's that irritating factor. That's that functional asterisk that's important. And that is what is done all day, right? Throughout our lives. That needs to be pain free for the human. And so that will be retrained. These kind of five go to treatments apply to to each of those subgroups. But what's different is you may spend more time on one of those five treatments than another, depending on the patient factors and common impairments associated with that subgroup. So let me tell you what I mean. So for that weak and pronated foot bucket, I'm going to spend more time strengthening the quads, the hammies, the glute max, and a lot of time on reactive neuromuscular control and that lateral hip to really help retrain that pronated foot that happens falling into pes planus with functional activities. Probably going to spend less time on modulating pain symptoms because in these humans, they are having overall less pain, and you're seeing them early on in care. The weak and tighter bucket, we're going to spend a lot more time probably on that modulation of symptoms. And then even ecosystem considerations fall into that, right? That person with higher incidence of pain and higher BMI, we need to talk about lifestyle factors, things that improve the overall ecosystem, lower inflammation, and then that will help reduce pain. And so we need that to be a big part of our care. Um, and we'll need to dial in strength of the quads, hamstrings, and glute max, and lateral hip, plus reactive neuromuscular control and multi-segmental joint retraining. So that weak and tighter bucket, I think, is going to be a little bit more challenging. But again, that five-step fitness forward approach is applicable. You're going to hit all five pretty well there. For that strong bucket, there's going to be less focus on the quadriceps, the hamstring, and glute strengthening, and lateral chain progressions. They'll be a part of care, but more minimal since strength foundation is pretty good there. You're going to spend more time on reactive neuromuscular control and multi-segmental functional retraining, so squatting, with little to no modulation of symptoms really required in this human. You can really get after it and retraining their whole system right away. So I presented a lot of information, right? We talked about what is patellofemoral pain syndrome, what are some subgroups suggested, why even do subgroups, and then I gave you this foolproof 5-step fitness forward approach. It is really, while it's a lot, it's pretty simple if you stick with those 5 steps. If you can think about subgroups to guide your treatment holistically, it it helps you give like a mindset that focuses on the whole human. So think about their patient factors and their impairments. The subgroups overall simplify both of those things, which allow for more targeted interventions for that subgroup. Ultimately, I want you to follow that 5-step fitness forward approach to caring for humans. And that is modulate symptoms, quadriceps, hamstring, and glute max strengthening, reactive neuromuscular re-ed, lateral hip progression, multi-segmental functional retraining. Those 5 steps need to be on board, just at varying degrees depending on which bucket. At Extremity Management Live course, we really dive deep into what those 5 things are in regards to our favorite exercises that we think are most effective. And then we really talk specifically about dosage of those 5 steps. So Mark and I would really love to see you all at Extremity Management Live to tell you how we've improved patellofemoral pain syndrome in people that have those pain symptoms. Thank you for joining me this Clinical Tuesday. I hope everyone has a lovely day, and I hope to see you in 2022. Cheers, everybody.